Good morning, my dear students. My today's topic of discussion is adverse drug reactions. Now, before going to adverse drug reactions, we must know what is adverse effect. Adverse effect is basically any undesirable or unintended consequence of drug administration. So it's a broad term. It includes all kinds of noxious effect like trivial, serious, and even fatal one. Now, as per WHO definition, response to a drug that is noxious and unintended and that occurs at doses used in human being for prophylaxis, diagnosis, or therapy of disease or for the modification of physiological function is known as adverse drug reaction. It excludes therapeutic failures, the overdose, that means the drug toxicity, the drug abuse, drug toxicity due to overdose, the non-compliance, that means if the patient is not complying, and the medication errors. Beside this, there is another term which is existing in this part of adverse drug reactions, that is called adverse drug event. It has been used to mean that any untoward medical occurrence that may present during treatment with a medicine but which does not necessarily have a causal relationship with the treatment. That means if you are getting Covishield vaccine or any COVID-19 vaccine, and if somebody had a stroke after 2 or 3 days, it does not necessarily mean that it is happened due to that particular vaccination. The idea is to record all adverse events first and then look for the causality only while analyzing the pooled data. So before that, you cannot conclude that this particular drug is responsible for the adverse drug reactions which is happening uh, after 1 day, 2 days, or even after 6 to 12 hours. So why are these ADRs a problem? The incidence of sufficient magnitude to be regarded as a public health problem. So nowadays it's basically becoming a part of public health program, this pharmacovigilance program, which is basically the prevention, assessment, monitoring of the ADRs. Only it is happening in 5% general practice, 5% are serious, whereas 30 to 60% are preventable. These are the most important thing. It may lead to failure of drug therapy, it may lead to withdrawal of the drugs already marketed, and huge socioeconomic burden is there with the problem of adverse drug reaction. All ADRs are not detected during drug development because, as we all know, that phase 1, phase 2, phase 3 trial are only done on few thousand patients and even few hundred patients. Only in case of phase 4, now the vaccination is given in few crore of people. Now we have a pool data and we can determine whether the ADR is actually happening due to the drug or not. The relatively homogeneous study, the populations are usually chosen, but the problem is in India, the homogeneous population is very difficult to find. There are some ADS occur only after long-term exposure and only on a background of concomitant illness. So, what are the drugs are being withdrawn from the market due to severe adverse drug reactions? The rofecoxib, which is basically a selective COX-2 inhibitor, usually used to minimize gastritis, but it causes myocardial infarction, hypertension, and hence been withdrawn from the market by the respective company. Cerevastatin, which is basically a hyperlipidemic drug, a statin-like drug causing rhabdomyolysis, so it's been withdrawn. Troglitazone is basically a drug used in type 2 diabetes mellitus causing hepatotoxicity, so it is also been withdrawn. Gravifloxacin is an antibiotic causing ventricular arrhythmia, so it is also withdrawn from the market. So all these are examples of the drugs which are being withdrawn following phase 4, that means following post-marketing surveillance and after getting the pool data. And the data is provided not only by the doctors, the sisters, those who are filling up the forms, but also by the patients. In UK, this kind of system is known as so. The ADR can be classified on the basis of its onset, its severity, and there is alphabetical classification as well as there is immunological classification. By onset, it can be classified into 4 types: acute, subacute, latent, and delayed. So, on the basis of severity, it can be mild, moderate, and severe. Mild means it does not affect, and basically it's like a side effect, and you have to accept it. Moderate one, is affects routine life. So for that you may require causal treatment. Severe is basically major disruption of life. Whereas on the basis of onset, the acute, it's all about timing. So if it is happening within 1 hour, then it's called acute. Delayed one is it's happening long after the exposure. So alphabetical classification is basically based on the alphabet A, B, C, D, and E. A stands for augmented, where extension is known. Pharmacological, on the known pharmacological effect is very common, often predictable, and usually dose dependent. More likely to be preventable, may or may not be related to drugs intended action. The examples are sedatives and drowsiness due to cetirizine. If you increase the dose of cetirizine, so you will see that the sedativeness will increase. The, there are so many other examples are being given with a type A1. Whereas the type B is called Bizarre type of reactions. It's basically idiosyncratic reactions. You cannot predict it. It's not very common. Not as I said, not predictable. Difficult to prevent. And examples are even eye drop of chloramphenicol may lead to bone marrow suppression, as well as uh, a total suppression of bone marrow may happen due to a dose dependent phenomenon of chloramphenicol. So basically it's a bizarre type. You don't know which one will ultimately cause the reaction like this, and it ultimately lead to aplastic anemia. So type A stands for augmented, type B stands for bizarre. Type C stands for chronic type of reactions. The occurs after prolonged exposure related to drug accumulation. It is predictable and preventable by regular supervision, and examples are phenacetin and nephropathy. Phenacetin is nowadays not used. It is replaced by its active metabolite paracetamol. So paracetamol doesn't cause nephropathy in that sense. So it's a safe drug comparatively. Type D is a delayed type of reaction. It has been seen in pregnancy. If you give it in the first trimester, probably you will see the problem after 6 or 9 months when the fetus is born as a baby. The structural and developmental anomalies. So type D reaction stands for delayed, C for chronic, and D for delayed. Type E stands for end of treatment. End of treatment means a person is supposed suffering from angina pectoris, and for that the patient is getting beta blockers. Now beta blockers are suppressing beta 1 receptors, and hence the adrenaline is not being able to coming in contact with the beta 1, because the beta blockers are basically the antagonist of adrenaline. Adrenaline is an agonist. Now suddenly the patient thinks that I will stop this medication because I am okay. Patient stop the medication, and immediately there is upregulation of the receptors, and they will bind with adrenaline, lead to cerebrovascular accident or stroke or hypertension, or it may lead to severe anginal attack or myocardial infarction. So that is the reason why this is called end of effect, and this is a very common example of this phenomenon. Bleomycin causes pulmonary fibrosis, which is a type B reaction. Corticosteroids causes osteoporosis, a type A reaction. Cyclophosphamide is causing hemorrhagic cystitis, that means a bladder hemorrhagic type A reaction. A for augmented. Cyclosporine causing nephrotoxicity, a type B reaction. These are all common reactions happen with, related to organ, but it is uh, the drug specific. But these drugs should be used by a clinician judiciously, considering the risk benefit ratio of the patient. As we all know that it has some kind of showing some kind of adverse drug reaction, we just cannot stop ourselves to prescribe these drugs. So here comes the knowledge, clinical skill of a clinician. As per immune reaction, we can classify it into 4 types. The most dangerous one is anaphylactic shock, that is type 1 reaction. And we are seeing physiological antagonism here, because histamine is released due to Ig mediated hypersensitivity reaction and destruction of mast cells. And these histamine receptors are H1 present in blood vessels and in the lung. In the blood vessels, it will cause vasodilatation, whereas in lung it is called bronchoconstriction. Whereas adrenaline binding with, when we are prescribing adrenaline for the treatment, it is prescribing binding with alpha 1 receptor in the blood vessels, and beta 2 receptors present in the lung. and causes vasoconstriction and bronchodilation, just opposite to that of histamine. So histamine is an agonist and adrenaline is an antagonist here. This is a kind of physiological antagonism. Type 2 reactions is an antigen antibody reaction seen with alpha methyl dopa, which is commonly prescribed in hypertension in pregnancy, and the hemolysis is the common phenomenon. Type 3 is a complement mediated immune complex deposition, where procamamide induced lupus reaction syndrome can be manifested with that, and we are observing this phenomenon. Whereas the type 4 one is a delayed hypersensitivity phenomenon, and this is seen with Mantoux test or tuberculin test. It is usually seen with the T cell receptor, and it's a delayed type of T cell reaction, happened usually after 48 hours. What is a serious ADR? If it is fatal, life-threatening, requires prolonged hospitalization, permanent disability, hospitalization, congenital anomaly, and intervention to prevent significant injury, then we can call it a serious ADR. Who are the more at risk of ADS? The extremes of age is the pregnancy, the breastfeeding, the people are the hepatic impairment, because metabolism primarily occurs at liver, the renal impairment because they are mostly excreted via kidney. So the accumulation will lead to drug toxicity, certain other illnesses like epilepsy, heart failure, and genetic polymorphism. ADR causality assessment can be assessed with the temporal relationship, which means how the time sequence of the event is related to drug administration. Previous knowledge, whether the drug is known to produce any such event in earlier recipients with a certain degree of consistency. So before giving COVID-19 related vaccination, this kind of history has been taken, and the form is filled up by the uh, person concerned who is taking the vaccination. De-challenge test, whether the event subsided on stopping the drug. Re-challenge test, which is ethically not permissible, where the event is reappeared when the drug was administered again. So that you cannot do in clinical practice, because the ethical reasons will prevent you from doing so. When will we avoid, how will we avoid these ADRs in clinical practice? The use of drugs only if really indicated. You have to avoid polypharmacy, which is probably not possible in case of the elderly people. You have to take care, and the useful drug history should be noted, well acquainted with the action and toxicity profile of the drug. You should not learn it from the medically representative, but you should learn it from your textbooks, whether it's pharmacology or medicine. Reading the book properly, you should know about this. The extra precaution should be taken with the new drug, as we are taking extra precaution with COVID vaccination. Are the adherents reported? The answer is going to be no, and the main problem is the lack of interest, awareness among uh, the people who are actually report these things. Nowadays, even the patients can report this, but the doctors, the pharmacists, the sisters, especially the sisters, are reporting this case sincerely, but most of the other people are not that much sincere regarding this in our country. Reporting systems mechanisms often do not exist. Only 2 to 4% of all ADRs are reported, and only 10% of the serious ADRs are reported in clinical practice. So it is often assumed that someone else will report, and that is the main problem. No one is ultimately going to report. The science and activities which are relating to the detection, assessment, and understanding, prevention of adverse effect or other drug-related problem is known as pharmacovigilance. Spontaneous ADR reporting, the intensive inpatient monitoring, prescription event monitoring, the database mining, the post-marketing surveillance, the clinical trials data, the other clinical studies are the strategies regarding this pharmacovigilance phenomenon. So initially, whenever myself or you people will report, you will report to the local center, that is the Department of Pharmacology at ESI Medical College. From there, it will go to Ghaziabad, which is related to CDSCO headquartered at New Delhi. Our eastern zone is in Kolkata here, and I'm sorry, this one is in Ghaziabad, as I said. This is our national center. From there, it will go to Uppsala, Sweden. So here, there they will monitor the adverse reaction of a particular drug happening all over the world, and from the pooled data they will see whether the significant adverse drug reactions are happening or not. On the basis of that, they will decide whether the drug can be prescribed further or it should be stopped immediately. And there is a PVPI app which you can always download in your smartphone. This is the form which you have to fill up. One thing you just have to remember, you should not disclose the identity of the person. Here you have to give the initial of the person. If the name of the person is Shaurin Roy, you must mention SR and or the registration number given in the outdoor ticket and the indoor ticket, nothing else. And rest of the things you can fill up just by reading the form. Uh, if three patient is getting 3 or 4, you have to mention all these 3 4, and you have to stop all medications because we are not sure which drug is responsible for causing this. We'll obviously demonstrate you in the practical part how to fill up this form, so don't worry about this. And at the end you have to sign. Don't worry, you need not have to face any problem. This report will be taken by the Department of Pharmacology, and from there we will refer it to the Department of, it will be submitted to the National Center of Ghaziabad. The registered center in Kolkata are SSKM hospitals and School of Tropical Medicine. These two are definitely registered. Few of the other are also probably medical college is also registered. So whom to report? As I mentioned before, you have to report in our department, and these are the places from where you will get the form. These are the sites. The field reporting form can be submitted to the MC or directly to the NCC. Now the patient also can do that. The reporter can also mail to this particular mailing address, and there is a toll-free number for reporting ADR. So all facilities are available regarding the reporting of adverse drug reactions. Terato means monster. So if a drug is causing monster-like feature of the fetus, it is called teratogens. So these factors, they can alter the normal intrauterine development in fetal growth and its structural abnormality, causing structural abnormality, physical functioning, and developmental anomalies. And that is called teratogenicity. This is basically a kind of type D adverse drug reaction. As per FDA pregnancy category, it can be classified into 5 types: A, B, C, D, and X. A is basically the drugs like thyroxine, insulin, folic acid, iron, which can be given in first trimester. There is no such control studies. They have shown no risk in this trimester. Animal studies show no risk in type B, but in some animals probably show. But these in B, the human trial has shown no such adverse drug reactions. So paracetamol, chloroquine-like drugs can be given. These are actually safe drugs for us. Track C onwards, we are actually measuring risk-benefit ratio. And animal studies show risk as well as the human studies also show some kind of risk. Like atropine, aspirin, ciprofloxacin are the examples. Type D reactions are the reactions happen in human fetus, and it benefits actually mostly the risk is more. The doxycycline, methotrexate are the drug, but there are certain situations where you may have to prescribe type D drug. Where type X drugs is basically a drug for which you can be taken to the court. So you should not prescribe X drug. And one such example is thalidomide. Thalidomide was thalidomide was invented in 1962 in Germany, and it was given for as an anti-anxiety sedative hypnotic drug to the mother, pregnant woman, and it's been seen that the babies are born with phocomelia, which means loss of limbs, both upper and lower limbs. So that is the problem, and hence it has been banned at that time. But nowadays there has been a resurgence of thalidomide, and this drug is now prescribed not in pregnant women but in case of multiple myeloma, intractable rheumatoid arthritis in other cases. So with this actually I'm going to conclude, but you just have to remember the first trimester, that is at the first 17 days, there is a all or none phenomenon in case of pregnancy. Either the child will die or the child will survive. Whereas in case of any drug, uh, after 17 days onwards to 55 days, it's called the developmental phase, and that is the most important first trimester, where you have to be very judicious, and the most of the developmental anomalies are being seen in this organogenesis phase. Then comes the next phase, and it phase will continue till the third trimester onwards. So in this phase, many of the drugs are safer in comparison to the first phase, that is the organogenesis phase. So ultimately, I'm concluding with the statement that there are no safe drugs, or rather, there are no drugs without adverse drug reactions. There are only safe doctors. So doctors, they should have adequate knowledge, they should have courage, and they should have a very good clinical acumen to prescribe any of the such medications. Thank you so much for your patient hearing.